which infectious organism has been isolated by PCR from the aqueous humor of patients with ICE syndromes? I'll give you a few moments to answer. All right, so we're sort of split across a couple answers there, so hopefully we'll have the chance to know the answer here in a few moments. So can we have Dr. Blyden's slides? Thank you. So this is Laura Blyden, and she'll be presenting on ICE syndrome. Thanks.
Good afternoon, everyone. I always like to say my pediatric glaucoma clinic is kind of like board review. So this is going to be a board review kind of talk. These are my disclosures, which, as you know, for ICE don't apply to anything because everything's off-label. And while we usually thank our advisors and inspirers before the talk, I could not have put this talk together without the help of Kirk Wilhelmus, Alice Matoba, and indirectly Dan Jones, because my goal here was to show you as many beautiful photos of ICE as I could possibly do, because as you'll see, we don't have much other information on the disease. So the pathogenesis of ICE. What do we know about this condition? We know that it is likely due to endothelial metaplasia into epithelial-like cells that begins to behave like epithelial downgrowth. It is most likely induced by a viral infection. We think it's herpes simplex virus. That's what most of the evidence shows us from isolates from the cell cultures themselves, as well as from PCR in our patients. However, there have been a few reports of antiviral therapy aimed at controlling the virus, which don't seem to delay the course or change the overall prognosis of the disease. So it's still a little bit controversial. We know that 70% of ICE patients end up getting glaucoma, and about 50% of those patients who have glaucoma go on to require surgical intervention in order to manage their disease. But what don't we know? We don't know how to reliably predict who needs glaucoma surgery earlier than when it becomes very obvious. And however, we do know that in general, the more iris involvement that you have, the more chance you're going to have of ending up with glaucoma surgery, but that's not that predictable either. The clinical presentation of ICE is 90% unilateral. This is across the board in different ethnic populations. It's usually female. It typically presents in the 30s to 40s. However, there are very young case reports into 10 and 12 and 14-year-olds. I personally think I have a 5-year-old with ICE, but I can't get him to sit still long enough to do the specular microscopy. Maybe next year I'll be able to update you. Glaucoma occurs in about 70%, as I told you, and it's not very common. ICE, you may find in your entire practice, you'll see a handful of patients with ICE in all the various presentations of it. You always want to exclude other causes if it's bilateral, such as PPMD, Axenfeld-Rieger, and Fuchs endothelial dystrophy. The demographics of what we know here, the largest case series that we have in the literature comes out of India. Most of those patients had progressive iris atrophy. It's consistent with what we've all been taught. And then there was a smaller population, a series from China. These were all from a glaucoma clinic, and most of those patients had either Chandler syndrome or Cogan-Reese. So there may be some variations in the type of the subset of ICE that presents depending on the ethnicity. Diagnostically, this is confirmed by the presence of ICE cells on specular microscopy or confocal microscopy, which give the beaten metal appearance to the endothelial surface, and these cells proliferate to manifest into one of the 3 subsets of the disease, which is either corneal findings, iris findings, or angle findings. This is what the standing electron microscopy of those abnormal cells look like on the back surface of the cornea, as well as on the surface of the iris producing the nodules. And these are just some pretty pathology slides showing you how that membrane proliferates through the entire anterior segment and across the iris to make the nodules. Chandler syndrome is what we typically is the mildest variant in terms of how it presents with glaucoma, and it shows corneal edema at lower than expected IOP with a nice cloudy cornea even in normal ranges. The pathognomonic, confocal, and specular microscopy findings can be seen here with the middle picture showing hyperreflective nuclei on confocal microscopy, and the picture to the far right of the screen showing the dark light reversal of the cells, where you have light borders and dark cells in ICE patients versus the normal configuration that you see to the left. The iris findings are quite pretty to see, but as you kind of go down the road with these patients, they can be very difficult to deal with. And they span both the iris nevus configuration, where this membrane goes across and pinches off the normal iris tissue into these pseudonevi, or to progressive iris atrophy, which can leave patients with debilitating glare. Because of that, we get high broad PAS in the anterior chamber, and if the cornea is cloudy, sometimes UBM or ASOCT can help you delineate how much of a burden of PS there are in these patients. Unfortunately, the management ends up putting you in this vicious cycle that our glaucoma colleagues and our cornea colleagues know very well, which is that you end up with increased pressure, which causes corneal edema, then they need a corneal transplant, then they have glaucoma, and the glaucoma causes problems with the cornea, and they go through this vicious loop over and over and over again. In corneal disease, the literature suggests that DSEC and PKP both do okay for ICE. There are similar failure rates and survival rates for both PKP and DSEC in the published literature, so most of our cornea colleagues would agree that DSEC is worth a try in terms of the safety profile, and it is likely better than DMEC because the DSEC tissue has a little bit of a ridge that those cells may find harder to migrate over. For glaucoma, we're left with our traditional choices: trabeculectomy, tube shunts, or laser, and obviously is there a role for MIGS in these eyes? The series out of India showed that 16 eyes underwent trabeculectomy with mitomycin. Traditionally, we were always taught that ICE patients were not good candidates for trabeculectomy. However, there is some moderate success with trabeculectomy, and in keeping with prior literature, there's about a 60% success rate at a year, which tapers down to 30 to 40% success at about 3 to 5 years, which overall, considering the population, is not terrible. Tube shunts are probably a much better choice for our iris atrophy or Cogan-Reese patients. The corneas may do better with sulcus or pars plana placement if that's an option. And then we can also talk a little bit about what I like to call our hybrid procedures, which are the Zen, the Expression, and the PreserFlow or InFocus. I have absolutely no information about the Express or the PreserFlow, but there is a small case series of 4 patients with ICE who got Zen gel stents that seem to be doing well about 6 months out. So it might be long enough to avoid the complications. Laser is also something I really don't have any evidence to tell you. Although looking at an anterior chamber like this, I can tell you right now SLT and ALT is probably not a good idea. There is one case report on cyclophotocoagulation that came out of the days when we were doing YAG, transscleral cyclophotocoagulation, and this is actually, I think, the report that everyone cites when we worry about sympathetic ophthalmia in those patients. So I can't tell you yes or no on that, but it's probably not a bad option if you're left with nothing else. There is a series about goniotomy, traditional goniotomy in Chandler syndrome patients. Even after a failed trab or tube, this may work. However, I'll tell you that in any patient with severe iris findings or broad PAS, you have to be able to see the trabecular meshwork in order to operate on it. So I would not necessarily recommend that. And there's no evidence on any of the angle-based devices or supraciliary shunts. So the take-home message for our ICE patients is that just like Lombard Street, it's very pretty to look at but difficult to navigate, and we get lots of pretty pictures for this very ugly disease. And fortunately, these are young patients, so they have a long way to go in the course of their life. Filters can work, tubes do work, but you end up in a vicious cycle with the cornea specialist. And please, whoever is brave enough to try anything new in these patients, publish your work, because there's a gross lack of evidence in the literature on these specialized patients. If I can get my audience response message up there, and we'll see if you guys learned anything.
Excellent.